The Division of Rheumatology was born in 1971. Its coming into being is closely linked to the life of one great woman, Dr. Lourdes Manahan. In 1953, Dr. Lourdes Manahan joined the Department of Medicine. She headed the PGH dispensary where she accumulated patients with gouty and rheumatoid arthritis. After a few years, she went to the United States to study with prominent rheumatologists in several teaching hospitals. Upon her return to the Philippines in 1962, she laid the groundwork for the subspecialty and established the section of rheumatology in the Department of Medicine, now known as the Division of Rheumatology. During those early years, Dr. Manahan was the section of rheumatology. As the only rheumatologist in the country, she multitasked as clinician, teacher, researcher, and mentor. She was professor in the College of Medicine and the doctor in our charity outpatient department arthritis clinic as well. She represented the country in various international fora, putting the Philippines and the University of the Philippines in the international rheumatology community. In 1968, Dr. Clemente Amante came home from his rheumatology training in the US and joined Dr. Manahan in the section. He helped Dr. Manahan in the Herculean effort to establish the fledgling subspecialty and attract trainees to the field. In 1981, a formal fellowship program in rheumatology at PGH was established, the first of its kind in the Philippines, with Dr. Rosario Nadora as the first fellow in training. From there, the section of rheumatology grew, and by the late 1980s, the section had graduated 5 rheumatologists, all of whom stayed in the country to render service. Interest in the field boomed in the 90s, and after 40 years, its graduates can be found in 15 of the 18 regions of the country, serving patients with rheumatic diseases. The division is continually involved in the undergraduate teaching of the College of Medicine by participating in learning units for 2nd to 5th year. It also actively participates in the residency training of the Department of Medicine. The residents' subspecialty rotation exposes them to more rheumatic diseases common in the country and to the details of diagnosis and management that are often not seen in the general services. The division reaches out to update doctors about developments in rheumatology through the Lourdes Manahan Lectures in Rheumatology. On its 18th year, this postgraduate course is held annually in the PGH but has also traveled to many provinces in Luzon and Mindanao before the pandemic. We also engage with our patients outside the clinics through the Lupus Club of PGH and Abacada ng Rheuma lectures at the PGH OPD and social media through Facebook and the division website page. The division staff continues to pursue the zeal for research and discovery in medicine and rheumatology that Dr. Manahan inculcated. Its publications have found a niche in local and international books and journals. Amidst the present pandemic, the division continues its tasks to educate, to discover, and to serve. We embrace the mission of service to the underserved and to those with rheumatic diseases. As we celebrate the Golden Jubilee of the Division of Rheumatology, we strive to continue the legacy of its founding faculty in training competent specialists to care for our patients, produce relevant researches, and serve the country.
In this video, we will learn about the logical choice to maximize clinical benefit in osteoarthritis patients. Hip and knee osteoarthritis was ranked as the 11th highest contributor to global disability, but often results in joint replacement surgery. The global prevalence of knee osteoarthritis was 4%, and the measures to stop the progression of the disease, reduce the impact on patients' quality of life, and restrict the burden on healthcare resources needs to be looked into. The European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis recommends that prescription crystalline glucosamine sulfate should be differentiated from other glucosamine formulations. Pooled results using the prescription crystalline glucosamine sulfate, a rotamycin preparation, was superior than placebo in the treatment of pain related to symptomatic osteoarthritis, whereas non-rotamycin preparation failed to show benefit for pain. Prescription crystalline glucosamine sulfate and paracetamol for rescue analgesia can only be used as background therapy for osteoarthritis, as recommended by the European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis. Viatril S, a prescription crystalline glucosamine sulfate, has showed superior outcome on pain with a small effect size of -0.27 compared to other glucosamine preparations. Different glucosamine preparations showed brand-specific heterogeneity in pain reduction. The effect size for Viatril S was moderate, and it achieved 48% reduction in the use of NSAIDs. The use of NSAIDs could be reduced by 36% and 48% by taking Viatril S for 2 months and greater than 4 months respectively. Viatril S is superior to other glucosamine preparations in the treatment of functional impairment resulting from symptomatic osteoarthritis. Glucosamine, administered orally as crystalline glucosamine sulfate, is bioavailable both systemically and at the site of action in osteoarthritis patients. Patients previously on prescription crystalline glucosamine sulfate experienced a 57% of reduction in the risk of undergoing total knee replacement. The cumulative incidence of total knee replacement was significantly decreased during a follow-up of 5 years in 275 patients with knee osteoarthritis, receiving oral prescription crystalline glucosamine sulfate 1500 mg once daily for at least previous 12 months. The European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis Task Force advocates the differentiation of prescription crystalline glucosamine sulfate compared to other glucosamine preparations. Prescription crystalline glucosamine sulfate is the logical choice to maximize clinical benefits in osteoarthritis patients.
Good afternoon. We are coming to you live from the University of the Philippines, Manila, for the 18th Lourdes Manahan Lectures in Rheumatology. I am Dr. Angeline-Therese Santiago, a Clinical Associate Professor of Medicine from the division, and I will be moderating this session. I would like to thank our sponsor, Viatris, for participating in this webinar. And to all our participants, thank you for joining us today. If you have any questions, you can place them in the Q&A box, and we will address them during the open forum and after the lecture. You will receive your certificate of participation in this webinar a week after you submit the evaluation form and post-test. The link will be posted in the Q&A box and in the chat box midway through the webinar. The Lourdes Manahan Lectures in Rheumatology, or LMLR, is an annual event currently in the form of a lecture series hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. The second of this year's LMLR lecture series will focus on osteoarthritis and osteoporosis. We are blessed today to have as our speaker the pioneer of this memorial lecture, which she established back in 2004, and it is my honor to introduce her to you. Our speaker finished her medical education at Cebu Institute of Medicine and completed residency in Velez General Hospital. She pursued training in rheumatology in Philippine General Hospital and did further studies at the George Washington University, St. Louis, Missouri, USA. She is the past chair of the Division of Rheumatology, both in the Philippine General Hospital and East Avenue Medical Center. Osteoarthritis is one of the special topics of interest of Dr. Penserga. She is the founding member and chairperson of the Asian Osteoarthritis Network and is a current member of the Lancet Osteoarthritis Commission. She has published numerous researches in osteoarthritis, crystal arthropathies, lupus, rheumatoid arthritis, and soft tissue rheumatism. Dr. Penserga is also a consistent Best Teacher awardee and received the Philippine College of Physicians Exemplar for Clinical Education Award in 2013. She is definitely a trailblazer in the field of rheumatology. But more than that, she is a caring mentor and mother to us, her trainees and students. Let us welcome Dr. Ester Penserga to discuss bringing osteoporosis and osteoarthritis treatments to the community.
Good afternoon, ladies and gentlemen. The topic for today's Dr. Lourdes Manahan Lectures in Rheumatology is a very timely one, and maybe even a long time coming. It makes us look at beyond the patient across our clinic table and onto the community. And therefore, when we sit in conferences like this and try to get what's best and current for our patients, we now look at what we can and how this can be translated to be able to serve the patients in the community, those with osteoarthritis and osteoporosis. So for today's conference, we shall be tackling on some concepts which shall be recurring in the subsequent slides, that of community, high-income countries, low and middle-income countries, and the shared medical decision-making. We shall talk of patients' perspective more and more at this time, and also the healthcare providers' role in the community. And we are just part of that team in the community. So we shall go to the definition of community. It's really a group of people living in a particular place. And if we consider the communities that will be talked about in this meeting, we consider the community that is in the Philippines. And the Philippines is now categorized by World Bank as belonging to the low and middle income countries. And being such, we are among those, our population is among those that comprise 2/3 of the world population. And we are in a category where healthcare is not really fully subsidized by government. The other important issue is that it's an observation that musculoskeletal disease prevalence is higher in low and middle income countries, and more so, it's increasing. This table is dated, of course, 2015, but it's a global burden of disease report. And we see here that osteoarthritis has gone up at least 6 rungs in the past 25 years as a major and important cause of years lived in disability. And so the other important study that is more recent is the group of Olsen, which surveyed 6 low and middle income countries, Ghana, Mexico, Russia, China, South Africa, and India. and found this prevalence of up to almost 5% of females and 3.1% of males with osteoarthritis. It's self-reported or diagnosed by the healthcare or symptom-based algorithm diagnosis. And that more of these arthritis happen with the least educated, the separated, and the widowed women. Now, if we look at this diagram, this is common, and about mid-2000, the evidence-based medicine group has given us this illustration on how the individual clinical expertise of the specialist or the doctor interacts with the best external evidence and the patient. But I would cite a similar diagram for evidence-based medicine, where the knowledge and skills of physicians or the healthcare providers in our case is on level footing with the patient, and both would aim at discovering the best available evidence or discussing, and then coming down to a clinical decision. So this is a setup where evidence is still the core, the best available evidence is still the core, much like this, but then it's expanded to include that clinical decision making. And this is a publication in 2020 by the group of Walden, where again, the healthcare provider and the patient are placed in equal footing, and they would meet, and the healthcare provider is there to have the skill and the knowledge of high value versus low value care, which I will explain later in the next slide. Evidences for and against an intervention is part of the healthcare provider's side or work, and the healthcare provider with this model should be patient and wait for the time to arrive at a common decision. The patient, on the other hand, also carries to the table her own perceptions, knowledge, worldview, values, and preferences. And finally, in the manner of discussion with the healthcare provider, acceptance should be the end result of this encounter. At the bottom, I just placed healthcare system because this is the most important part of this interaction, whether there is a system that in fact can carry out what has been decided upon. Now let's go to the healthcare provider side. And on our side, we are expected to know high value care, term which I borrowed from the West Australian government. Australia being a high income country, and therefore they subsidize healthcare of their population. And in that way, they need to determine high value care by way of being effective with strong evidence over other available alternatives. It should be safe and that's important, cost effective. We shall see that high income countries still look for the most cost effective intervention that can be offered, that the government can offer the patient. Opposite, of course, is low value care. It's worth mentioning that these ineffective sort of maybe drugs or diagnostics can absolutely be ineffective, but they can also have been in a conditional category in many clinical guidelines, but then lost after a sizable amount of evidence have been accrued to remove it from or upgrade it in the recommendation list. But it can also be popular And we have a lot of that in the country and more available at that. So there's potential harm and the cost is not it's not cost effective. So now we go to the patient. This is a study by Darlow which is a focus group discussion, qualitative study, which sought what the patient's takeaway thoughts and decisions were after being given an intervention of education about osteoarthritis. And lo and behold, while we explain the disease and the treatment to the patient, we see that they will carry away some their thoughts, infused, of course, with their values and their perspective. So one says, in fact, during activity wears out my knee, and there is activity that is told is good for my knees. So it's a certainty. I want to make the most of my active life while I still can, and that's a decision. I would rather ignore my knees. Another decision. Medications help my pain, and I need to keep going. So there's a worldview, a personal view about how to handle disease. On the other hand, the same study says that there's some uncertainty that after education as an intervention. One patient observed that this is what she carried away. There is activity that is right for me, and activities good for my knees are not often right for me. Okay, so there's, I don't want to wear out my knee faster. I need to plan my life around my knee, something hopefully not catastrophizing. Medications do not fix my knee. I need to rest and pace. But just let me add, anecdotally, this is what I observe in my patients after explaining and in terms of treatment, what do they usually ask, and therefore is possibly a link to what they're really thinking. Anong side effects do? Magkano kaya yan do? And the more common, kayo na po ang bahala do. So these are things that we need as physicians to think of when after our patient encounter. So osteoarthritis and osteoporosis are the topics in contention today, and I see them as the two sides of a coin, and the coin is age, being the two diseases being common in the elderly. And I listed here 4 attributes that we might really want to focus on. That's the physical capacity of the patient at that certain age, the comorbid conditions that she may carry, she or he may carry, polypharmacy, and if he or she has the resources to buy the medications or to do the laboratories. Let's take a case, for instance. This is an older elderly, 74 female, living in Paniki, Tarlac, a first-class community, but it's still more of the rural side. Bilateral knee pain, which is chronic from age 60, tolerable, and goes away after moving about. Possibly it's part stiffness, less of morning stiffness. And then aggravating factors and relieving factors, liniments, very important. And after age 70, she needed, so there's progression. She needed to take a tablet for arthritis at this time. And further, she now notices grating or clicking sensation, which bothers her. And more, the patient's children insists that she gets an X-ray. And then 4 years prior to this consult, she fell from a street curb. So from a standing height, broke her wrist and is given calcium. She has here her comorbid conditions. She has medications, polypharmacy in sense, and there is an additional data on numbness of the fingers and foot, important to in stability matters, and falls. And then she also noticed that she has become bent and is now shorter in height. So there you go. Let's go to the patient's knees first. When we diagnose osteoarthritis, we almost always certainly have x-rays in mind. However, we should realize that the American College of Rheumatology in 2005 up to the present has given us a way that is very suited to the community. We use history and PE alone. So the entry criteria being pain in the knee, and we just add 3 of these clinical, highly specific clinical attributes. So that's age 50, more than 50, less than 30 minutes of morning stiffness, crepitus and active motion, bony tenderness, bony enlargement, and palpable warmth. So PE findings. These are subjective. No? So very easy to diagnose osteoarthritis in the community. Using history and PE plus radiographic findings, we have the same history here, details, and with the X-ray radiographic findings of loss of joint space, sclerotic margins, and osteophytes, we just add 1 clinical data, age over 50, and then there you got it. And if you are maybe in a more urban setting, then you can have laboratories, and with the clinical data, we want to verify if there's an ESR that is non-inflammatory, a rheumatoid factor that is not there, less than 1 to 40 titer, and if there's synovial fluid, then the count should, and chemistry there should be non-inflammatory. So there you go. We have hit 1 modality that we can bring to the community. Then what can be low-value diagnostic tests? For one, the X-ray, in this setting, therefore, where we can in fact diagnose by clinical grounds alone, will become a low-value diagnostic test, because then it will not be really that cost-effective. And so that's already a given. And besides, X-ray is not sensitive in picking up the early pathologic lesions of osteoarthritis. And if we want the X-ray to be the sole diagnostic, we will need at least 3 views. That's the PA, the skyline view, and the lateral view, which is almost 100% sensitive, close to 100% sensitivity for osteoarthritis. What about the other laboratory imaging techniques? We have MRI, quite common and especially indicated, not for diagnosis, but to detect intra-articular pathology that may warrant surgical referral. And CT scans, the same, picks up inflammation, synovitis, bone marrow lesions that are closely tied to the pain of the patient, pain sensation of the patient. And this with the less added radiation from MRI, and the joint ultrasound, which is becoming more popular, especially with the younger rheumatologists with training. And they can bring this around like the ECG machine. It can be brought to the clinic. So there again, you can visualize intra-articular pathology. But for diagnosis, for now, we don't really use these imaging techniques. How about treatment? You have here a list of a table of 4 clinical practice guidelines that I just chose personally because they are the living guideline documents. Ever so often, they have updates and upgrades. And one sees that the main treatment for osteoarthritis pain, maintenance of function, and prevention of disability is patient education, exercise, and weight loss for the obese. And all of these guidelines agree, plus topical NSAIDs for the acute, perhaps for the acute episodes of low-grade inflammation we do get with osteoarthritis. And one can see that this can prove to be much, much lower in expense for government. Now, education, for one, starts in the doctor's clinic. And we saw that even if we have done it, our patients may have a very varied response and thoughts about it. But anyway, the usual clinic education is when we verbally explain, we get the x-ray perhaps and point to items on the plate, or use a model, a joint model, and hope that the patient will understand and fully get it. However, reading materials are also important. So just to advertise that the Division of Rheumatology of the Philippine Hospital has comics for several of these conditions that the patients can enjoy and read at the same, and be educated at the same time. Exercise program, there are land-based exercises and water-based exercises. Recent data on water-based exercises is, I think, strong and would join the recommendations of these groups of networks of bone specialists, bone and joint specialists. And the exercise should focus on strengthening the muscles around the joints. And we're referring to exercises designed for the quads, the abductors, adductors, but there are modifications, of course, which I will discuss later. And weight loss for the obese. Way before, that is the first issues of the Framingham data, 1985 to the early 1990s. They actually, by mid, I think very early 2000 or late 1990s, they were able to put out the study on relief of pain by 50% with 5% loss of weight. And I continue to use that, the rule of 5. 5% weight loss, then 50% pain relief. It is actually equivalent to or close to what's current, and it is when a patient loses one step of the BMI from obese, for instance, to overweight. The relief of pain has been estimated to be at 33%. And so if you go on and lose some more weight to become normal, then that will be about 65%. And these are numbers that you could work with the patient and give the patient that a stakeholder's position on his own treatment. And so this can be done in about 6 months, and it's therefore very realistic for the patient, can be very realistic for the patient. How about NSAIDs now? We try to, even paracetamol or one has been placed unconditional because of the more and more data coming in about their effects in the GI tract and kidneys. And of course, NSAIDs and COXIBs have been long ago on listed as conditional recommendations. Glucosamine is one of those that have been removed by ACR as not recommended. This is the glucosamine hydrochloride preparation, but one sees that it's still on with SKO, a European group, which uses in their studies glucosamine microcrystalline sulfate preparation. Chondroitin is conditional for hand osteoarthritis. So if you look at high value care, I'd list this 4, and this can be offered to the community. I believe so. Now, going to the EULAR recommendations, back to the EULAR recommendations, because the drug recommendations for EULAR actually, I think, was 2015, but the 2018 recommendation I cited back in the table had a more expanded view. It was for healthcare professionals, and those were targeted were inflammatory arthritis and osteoarthritis. Therefore, what I like about these recommendations, these are a list of 11 recommendations, is that it should be patient-centered. Therefore, pain assessment should be detailed. The patient's needs, preferences, priorities, and management should be respected and explored. And this should be pitted against his values, activities, and goals. This rings a bell personally because I know a patient, 92-year-old, post surgery from a fragility fracture, and she's in the US now. And at the physiatrist, the clinic, onto the rehab medicine physical therapy program, she was asked, "What is it you love to do and enjoy doing prior to surgery?" And she mentioned that she loved ballroom dancing and likes the cha-cha, to dance the cha-cha. And now when family members would ask when can she be discharged from physical therapy, the physical therapist would answer readily, "Oh, very soon when she can already dance the cha-cha." So that's how things go currently, and I think it's really the best for the patient. The evidence-based treatment is from clinical guidelines. You choose which you have reviewed very well, but the aim really is for a shared decision. And again, this is time-consuming. Step care approach is another important process that can be brought to the community. We can make use of the resources of the rural health unit, the midwives and the nurses who are there daily, and the doctor maybe once a month. And when the pain and the patient's problem is still not fully achieved, relieved, then a subspecialist with a networking setup can be tapped close by and available for consult. So that's the step care approach. We also need to know the other non-pharmacologic treatment, because this recommendation lists anxiety and depression. Truly, it affects the pain sensation of the patient. Sleep intervention, very important among these other modalities before the drug and the joint specific treatment. So now let's go back to our patient. So what can we offer our patient in the community? She can be diagnosed without x-ray, actually, pain, age, the morning stiffness, and then crepitus and motion. And then treatment, she's a teacher. She might be very willing to learn, always learn. The exercise, personally, I have chosen 3 YouTube videos I give to the elderly, one that is seated and is only about 7 minutes that can be repeated during the day. And then there's an exercise, 2 slow aerobics that can be given to the younger elderlies. Weight management, we have already give numbers to the patients and targets. And topical NSAID. I would rather get this patient topical NSAID. How about psychological support? We should tap the family for psychological support. And this is very important because the Philippines is one of those that have the extended family setup. And we have family members that can bring the patient to the clinic, the doctor's clinic, and buy their medications for them, cook for them. However, very graphic example here was only last week when I had a teleclinic, and the gadget was prepared on the side of the patient by the doctor, and she readily reported, "Doktora, ito kasi siya, naglalaba pa rin." So upon asking the patient, it was actually just her underwear. Every time she bathes, that she washes. And therefore, I told the doctor, "Oh, please let her do that. She can feel useful and also needed." Therefore, just precautions on the wet floors, things like those. Those are possibly very amenable to include in programs that we can do for the patient. So, an individual patient in the community, we were able to get what other things we can bring to the community at large. We'll now go to the fracture. And we know that she has calcium on. What are the interventions we can give for osteoporosis in the community? So for diagnosis, citing that patient, she had that incident fracture, first fracture, fragility, and therefore it's diagnostic for osteoporosis, subsequent recurrence of fractures. Remember that fragility, the first fracture in a postmenopausal person will mean that there's an increased risk for the next fracture. So it's very important to know that, although it is therefore already unnecessary at this time to really do all the DEXA, for instance, but there is an indication for DEXA for our patient. So diagnosis, we know that WHO recommendation, it's a T-score of -2.5 in all the major osteoporotic sites that are known to fracture. At -2.5, low trauma spine and hip fracture is also indicative of osteoporosis. Now, osteopenic levels plus a fragility fracture in the major sites, also diagnostic already, and osteopenic numbers with a high FRAX. No? This is the fracture risk assessment tool. We shall talk about at length in a little while. But this is a recommendation way back for screening for osteoporosis. However, now even high income countries are trying to find ways and means to mitigate expenses. And knowing that high specificity is the strength of DEXA, but again, there are readings that are osteopenic or normal, and yet they still come down with fractures. So going by our number of DEXA machines in 2019, it was reported that the Philippines has 21, more or less now, 2 years after, I don't know. Singapore has 98 or 100 for their 5 million people, 16.9 machine per million population. So you can see that this study, the next studies is from Singapore, but let's go first to OSTA. This is perhaps the best that we can bring to the community in terms of diagnosis or screening for osteoporosis in our patients who has yet no fractures. And I just want to point out, especially for our younger colleagues, that Dr. Tito Pitoralba was among the original authors of this paper. So the OSTA score uses just two. It's weight and age. And you just subtract the age, which should be higher, from the weight, and then multiply that by 0.2. And so we usually get negative integers here. And what is now known to be densitometrically equivalent to the T-score -2.5 is the high-risk score of less than -4. So a -5 increases the risk already to 4 to 6 times normal. And the low risk, of course, is those that are -1 or more up to the positive side, but I'm not sure how that happens. So here, if our patient is, let's say, by weight 54 kilos, and she is 70 years old, so this tool already places her in the medium category. However, because she has had a fracture, she is already here in the higher risk. She should be here already. O baka 49 kilos lang yun. Now, can we bring this to the community? Yes. And this is a very common insert in our takeaways from conventions. If you have this, please retrieve this and bring to the clinic. The other thing is the fracture risk assessment tool, or FRAX, which estimates the 10-year probability to fracture. Now, when I presented this personally to the patient, she said, ay, 10 years pa naman, Doc. Mabubuhay pa kaya ako ng ganyang katagal? So, somehow our patients have their own notions about how to use, how these tools can help them. But for us, it's something that we can use. It's in a gadget, and therefore, is it possible in the rural health areas? Maybe. And however, it's a little bit more complicated, but mitigated again by that being it's a calculator in a calculator form. What's its advantage is that it adds other risk factors. So height is there, previous fracture, parents with fractured hips, etc. And we have this paper from our colleague, Dr. Julie Liu and team, where we have already a Philippine FRAX, and go to Sheffield, this site, Sheffield AC UK, for the FRAX form with our flag, Philippine flag. And it said that the end we use the threshold for increased risk for fracture using the NOF cutoff, National Osteoporosis Foundation cutoff. I wonder, Julie, if this has changed over time. Can you please put in the chat box? And then the team of Dr. Caro Del Rosario and Dr. Tikman, our friends and colleagues too, they tried to validate and cross-culturally validate and translate this. And I found out that rheumatoid arthritis really was the lowest in hits during internal consistency issues, etc. And patients tend not to click it. And therefore, I think they changed this to road trauma instead. So that would be a good read, and we could pick it up sometime. This is what I said about a high-income country trying to find ways and means to use cheaper screening methods. And here, the FRAX threshold for major osteoporotic fractures in terms of probability is set at this small dot here, which is just close to 80% sensitivity. That's about 78% sensitivity. And I think the specificity they wanted here was 58, and that determined the AUC of about 0.77. And for hip fracture, it's 0.79. And compare that to OSTA, which is 82.8%. It's smaller, but more or less, it can cover for the people who would possibly be more at risk at a certain point in time. And so this group is actually looking at government to use the FRAX or instead of BMD to conserve funds and possibly using this for screening fracks, they would have only to send about almost just 9% of their suspects, high-risk patients for DEXA bone density measurement. Now, in treatment, I just I chose the American Academy of Clinical Endocrinologists for guide. Treat anybody with these scores, but already had a fracture. So this is still osteopenic up to the threshold of osteoporosis. Then osteoporosis by itself, the threshold is T-score of minus 2.5, treat, and then T-score of, again, a range from osteopenic to osteoporotic when there is a frax probability score to fracture in 10 years of more than 20%, or for the major sites, or more than 3% for the hip. What do we treat the patients with? Bisphosphonates still first line, but may I just mention that bisphosphonates by themselves really have very close and similar effects in terms of fracture risk reduction. Except for some sites with ibandronate, for instance, they are good for vertebral fractures, but for hip fractures, it's inconsistent. For anabolic therapy, teriparatide, indicated for very high fracture risk and those with multiple fractures. So if this were a DEXA reading of minus 3.6 or minus 4, then anabolic therapy would be indicated. And those on treatment with anabolic therapy should have calcium and, okay, those on treatment with conditions other than anabolic therapy. It should be other than anabolic therapy, meaning bisphosphonates and hormones and monoclonal antibodies, calcium and vitamin D should be prescribed. Monitoring for treatment response by BMD is 1 to 3 years interval. So again, the big groups of drugs we can give our patient: bisphosphonates. There are cheaper brands now of alendronate specifically. Then we have denosumab, I think. I'm not sure about romosozumab, if it's already here. And of course, the hormones. I did not include in the list the hormones because it's really quite expensive and also indicated during the first 10 years post-menopause. And therefore, they have very narrow indications. And calcium with vitamin D. The indication of calcium with vitamin D alone is when the patients would not tolerate bisphosphonates in whatever way. Side effects, unable to really follow or adhere to dosing, etc. So at best, the studies on calcium with vitamin D has actually resulted in contentious issues. The recent NOF, I think it's a network meta-analysis, if I'm correct, had generated a lot of exchange of letters by NOF and other groups that did not agree with how they extracted with how they concluded from their extracted data, specifically more about calcium with vitamin D. However, there is a place, we now know, on when the patients are unable to tolerate any other treatment. So how do we bring high-value treatment for osteoporosis to our community? First, we will look at adherence issue. Non-adherence, we should realize, is related to increased risk for non-vertebral fractures. So it's therefore very important that initiation of treatment, implementation, and persistence should be in our minds when we start the patient and prescribe, because outside the patient may not buy, initiate treatment, and when they start taking their medication, they may also not take it correctly, or even in terms of adherence and persistence, it's a very high mountain to climb for osteoporosis anti-osteoporosis drugs. And it's known that at 6 months, about 30% will drop off already from treatment. Factors: misconception and lack of perceived benefits. Very real. Patients would come and say, wala naman ako nararamdamang improvement. Masakit pa rin naman ang aking balakang, tuhod. The male, and low level of education, side effects, and dosing regimen. Adherence, therefore, should be sought through proper patient knowledge and education. When the patient has a paper to see, minus 2.5 na ako, that has been found to increase adherence, and also very good patient-doctor relationship also fosters adherence, and hospitalizations and prescriptions have also been associated with high initiation for osteoporotherapy. So, our patient, does she need DEXA to diagnose? No more. She is osteoporotic. Does she need DEXA to monitor treatment? Yes. And we can monitor her response to calcium with vitamin D. That's our usual preparation anyway. And for treatment, I would still love to give this patient bisphosphonates and calcium. So calcium has been in this paper, a 2019 publication. This has been shown that calcium with vitamin D prevents hip fracture with a significant fracture risk reduction for the hips. And vitamin D, of course, is known to improve muscle function and therefore has good effects on patients decreased in fall episodes. So for the Philippines, for our communities, we made this focus group discussion with urban and 2 groups of patients with knee and low back pain. That's for urban and rural. And the aim really was to list the patient's views and experiences about the treatment and the community resources, whether it's positively or negatively impacting on their condition. So do they have self-management resources? What activities are affected? And we sought for family support. And then outside the home, how they travel, how does it impact with the pain, impact on the pain, and how about the availability of doctors, priorities, which of their comorbids with their arthritis would be first in their list to consult a doctor with, and the effects of COVID. So this is what we got. An attitude of acceptance was really there among the 2 groups, in the 2 groups. Hindi naman siya masyadong nakaka-affect dahil tolerable naman. Pero kung hindi ko na kaya, mag-take lang ako ng Flanax. Okay? That's not an advertisement, but that's what they said. No? These are quotations. Ako walking. Nawawala ang sakit ng tuhod sa walking. Yung isa naman is careful. She holds on to something to stabilize her. And the tricycle in the communities natin, no? So tricycle, low seats really cause their pain, aggravates pain. And also the jeepneys, high steps. And I found out that because they have these self-management resources, liniments, many types of liniments, and they found that hassle and difficult to secure appointment. They prefer private practice doctors because the lines in health centers are mahaba. And one quote here that struck me was, ang daming senior dito sa amin, walang espesyalista sa rayuma. Sana makapunta sila kahit isa, once a month. And this is on prioritizing hypertension, thyroid nodule as the more urgent conditions to consult a physician with. So we had the patient views. At least this is a pilot study. Attitude of acceptance, pain usually is tolerable. There's available self-management modalities, and there's family support. There's sparks for walking, but the rest, board transportation, the availability of medical resources, and no specialists for arthritis. Therefore, if you look at the interrelationship of what health care should be, we possibly are missing with a great gap in local data on patient values and perspectives on disease and treatment. Therefore, this proposal has been presented to a technical working group of the DOH in 2017. And of course, it's overtaken by a lot of other things. So to simplify, the scope is national through the DOH and GURHU units with the first primary health care team, midwife, nurses, and doctors. And then the method is case finding or consultation, but diagnosing outright with the clinical diagnosis from ACR to 005, no need for x-rays, and for OSTA, for osteoporosis. We can at least do that in the community. And then we can do step care approach, as I explained earlier, from primary care to the nearby network of specialists. We hope that that's in the community. We're hopeful. And if the universal health care plans of PhilHealth will pursue up to the non-communicable diseases that should include already musculoskeletal diseases, then we might be ready with the proposal. So, in summary, high-value treatment for osteoarthritis and osteoporosis in the community is available. We can bring it there. Doctors and healthcare providers, we are equipped, but we are not just there. So data from foreign literature is not our data. So there's a need to know our patients more. And there's a gap, because there's a gap, big gap in our knowledge of how our patients really receive what we offer. And of course, community resources for our arthritis patients to be enacted as law literature. This is a summary of much work to do. But I think there are more of us now, as I give thanks to the Division of Rheumatology with Dr. Evelyn Salido leading. And I thank you for keeping the Dr. Lourdes Manahan lectures in rheumatology relevant and as relevant as ever. And to the fellows in training, especially those who worked with me for to be part of this lecture. With that, I thank you.
Thank you, Dr. Penserga, for your insightful lecture. We have some questions in the Q&A box, and I think Dr. Pen has already answered some of them, but maybe we can expound on them a bit more. So let us proceed in answering the questions. Okay. So there's a question here regarding osteoarthritis. What would you recommend to a patient with findings on osteoarthritis on X-ray, but has no symptoms yet?
Thank you for that question. That's one very important characteristic of osteoarthritis. In fact, only half the patients with X-ray findings will have symptoms. The rest will have none. The treatment for osteoarthritis really deals with their pain, any disabling discomfort. Some patients will just say it's uncomfortable. We may really also want to ask the patient that if there is no pain, is there discomfort? Why was the X-ray in fact done? So the patient must have sought consultation. But for screening, the X-ray will not be a good means to do screening because, again, the clinical symptomatology does not jive with X-ray findings. So I'd leave it at no treatment when there are already X-ray, even if there are X-ray changes. And I hope the X-ray changes are not really the bad ones with no more joint space, etc. That's an entirely different scenario. I hope I've answered your question. Just pursue it in a while if you have some more data for that patient. Thank you.
Thank you, Ma'am Pen. I think tama yun, Ma'am, no? We need to highlight the judicious use of diagnostics. And as you mentioned, you should not use your X-ray as a parang screening tool. Yeah. Another question, Ma'am Pen. Good afternoon po, Ma'am Pen. Thank you for always learning heavy lectures. Regarding weight loss in osteoarthritis for old patients, how do you advise them, keeping in mind the risk for sarcopenia among the elderly?
Well, the situation calls for individual assessment. And if this is a patient who is really obese and with multiple comorbids, many times they're hypertensive as well, and maybe even diabetic. And therefore, I usually hook them to the disease where they are more afraid of. Diba? Mas gusto nilang, naku, ang high blood, baka ma-stroke. And yet, when we explain that for the knee, we can put the goal. I usually do it with the number targets. And therefore, some of them are able to navigate with mga monitoring, but some of them would not come back because Doctora will weigh me again. And
Kinabahan, Ma'am.
yes, the other thing is also to hook it with muscle strengthening exercises. Remember that weight loss in the elderly is always very difficult. So we just hook it to exercises that will tone up muscles, and therefore mitigates sarcopenia that also is there already in the elderly stage in many patients. So I do it with numbers. I do it with linking it with the diseases that they have that they're afraid of. And then number 3 is really just toning them, not really outright losing weight.
Okay, thank you, Ma'am. So we have a comment that patients and even some doctors have this thinking that there is nothing that can be done for osteoarthritis and something that we must fight. And corollary to that, we have a question. What options can you give for elderly patients with KL4 osteoarthritis of the knee not amenable to knee replacement or surgery?
We have many of that in our population. And just to expand a little bit, we did a study with our osteoarthritis multidisciplinary clinic 2015 to 2016. And in fact, out of, I think there were 19 patients already qualified to have total joint arthroplasty. Only 7 underwent that procedure. So more than half the patients will be averse to surgery. Therefore, these patients will then have to undergo the exercise programs, and the exercise programs will be the number one for them. And if there is pain, there are several other means which are intra-articular or joint specific treatments that we can give the patient on a PRN basis. If they are in pain, then you can give it so that they don't stop their physical therapy or exercise program. And also still continue to convince them. We never stop.
Okay, thank you, ma'am. Another question from our chat box, or from our Q&A box. Thank you for the lecture, ma'am. I would just like to ask, since as stated in the lecture, topical NSAIDs were the pharmacologic treatment that was included in the high-value care. But we know that these medications are rather expensive. For the setting of the community or in low-income areas, what other pharmacological treatment may be used that can be near high-value care?
Oh, yan na ngayon. Near high-value care. Thank you for the question. And what I do with patients who would complain that a 350 peso tube, no, ointment is actually divided by how many days? 7 days at least. So you can do some math with your patient, convince them that actually ang 1 inch nito magagamit mo 2-3 beses maghapon, and then it can last you 1 week. So 350 will actually therefore be divided by 7, 50 pesos a day. So kung mahal pa rin yun, close to high value care, I would still continue to use paracetamol, because the condition there was for paracetamol to be beyond 4 grams a day. Not 2 to 4 grams a day. We be careful about that higher doses of paracetamol. So that would possibly be one, but alam nyo, the muscle strengthening exercises is fantastic. It really relieves pain. And if only we can transmit that properly to our patients. And in fact, one of the focus group discussion members we had said, sumasakit ang tuhod ko, I just walk for it. No? So apparently her knees are still good for walking, but the toning of the muscles during walking is the one that causes the pain to lessen or to be relieved.
Thank you, ma'am. And sometimes, ma'am, even just the use of a cane, right? Just the joint offloading, sometimes it helps a lot in pain management. So I guess a change in perspective, no, ma'am?
Yes, and also yung yung tawag noon, you taping, no?
Taping,
so
ma'am.
Taping of the patella, no? Ang patella, many times in patients who have very weak adductors, no, the medial muscles of the thigh, their patella will be pulled to the side by the lateral muscles, the stronger ones. So sometimes we just tape that's a physical therapy intervention, but I also do it in my clinic. I tape the patella towards the center between the femoral condyles where they should be. So that can also mitigate pain.
Okay, thank you, ma'am. Another question about osteoarthritis. Good afternoon, ma'am. Thank you for the high-yield lecture. What is the stand of PRA on the use of glucosamine for osteoarthritis?
Well, formally, there is no stand. We do not have a white paper for glucosamine, but on a personal scale, when we go to the Lancet data that they published in 2018, one can see that the preparation matters. So it's not just that the patient carries with him a supplement, glucosamine supplement, but the data that we have is still on the microcrystalline preparation, which is glucosamine sulfate. So, yan.
Okay, the pharmaceutical grade, ma'am. Okay, so before we proceed to our questions on osteoporosis, would you like to comment on the correct terminology? Do you still use the term degenerative osteoarthritis?
No more. We really want to shy away from that. And although it's an advocacy of our association and the rheumatologists, I'm sure, I think radiology and many of our orthopedic colleagues still call it a degenerative disease. And sometimes this scares the patient. There have been several patients who comes to the clinic with so much anxiety because degenerative has different connotations to different patients. So we should be very careful to use the term degenerative, especially in front of our patients.
Okay, for our students, that's something that we need to remember with the different mechanisms involved in osteoarthritis. So baka nakakatakot din sa patients if we tell them it's degenerative. So thank you for clarifying that, Ma'am Ben. So we have a couple of questions regarding osteoporosis. Is there any age beyond which it may not be worth it anymore to give bisphosphonates for osteoporosis? Is there a cutoff, ma'am?
Wala namang cut-off. I don't think there's a cut-off, but there's something there in that question that begs for an appraisal of the patient's osteoporosis. If it is already very severe, then we know that we need to shift to teriparatide, probably, the anabolic agents. So a patient at risk for a higher risk for multiple fractures beyond a T-score of beyond minus 2.5 or an OSTA score more than -4 will really need a reassessment for possible anabolic therapy.
Okay, thank you, ma'am. Another question. Is the 2011 Philippine guidelines on osteoporosis still recommending using FRAX high scores as guide to treatment for those without BMD testing, or do we follow now the 2020 AACE of treating those with high FRAX if only with osteopenia?
Well, there are two choices here actually in this question. It means that if you say there's osteopenia to be part of the treatment decision, then meaning dapat may BMD yan, because osteopenia is a number that has an equivalent in the BMD. However, we can use still the OSTA. I'm quite convinced really of the OSTA at this time after reviewing for this lecture, because you do have a -1 to -4 intermediate risk. And therefore, that could coincide very nicely, although for OSTA, I think it's more of the -4 that is densitometrically already calculated to denote a -2.5, ang -4 and lower. But if you go by -1 to -2 to -3, that could, I think, in the clinics, we can, I'm not privy to any data, hard data here. We can ask the osteoporosis subspecialist in the group, but I think the corresponding, if there's no BMD, the corresponding OSTA scores, or if there's already a FRAX score that is high, high risk, then possibly you really need to treat already. So, sana hindi na muna magpa-BMD. That's actually the message, no? We sometimes osteoarthritis X-ray, osteoporosis BMD, gano'n na kaagad tayo. When in fact, we really have tools in hand, short of getting them to spend for those imaging studies.
Thank you, ma'am. And we have one last question from Dr. Del Rosario. Let's just go back to osteoarthritis. Would wearing knee support be tantamount to patellar taping?
Dory, thank you for the question. But my answer would be I don't think so. I don't really have data, but there are knee braces that have a hole in the middle, supposedly for patella, where the patella should be. And I'm just thinking now that if it were a good fit, you can put the patella in actually into that hole, and it would serve also to keep the patella in place. But I don't know how good your braces can do that. Maybe we ask the better half of Dr. Magbutang.
I'll ask him later, ma'am.
Please ask him.
Yes. So, thank you, Dr. Pen, Ma'am Pen, for answering those questions and for that very insightful lecture. I am sure our audience learned a lot from you today. I certainly did. Thank you also to our audience for their interesting questions. This afternoon, we learned a lot about two topics that are very common in our elderly population, osteoarthritis and osteoporosis. And this is something that we really need to improve our care. And Dr. Penserga gave us important points on how to give high level of care to our patients, especially at the level of the community. She highlighted a shared decision-making between, or a shared model of care between the healthcare provider, the patient, and even the healthcare system. And other approaches, such as a step care approach, it doesn't need to be specialist-centered. We need to get our primary care physicians involved, or other healthcare workers involved in the management of our patients. And of course, the need to use our clinical acumen in our clinical tools and not just rely on diagnostic tests to diagnose our patients, because really, we don't really need expensive tools to diagnose and manage these two conditions. And finally, let us remember that these musculoskeletal problems and even arthritis are on the rise, especially in low to middle income countries, which includes the Philippines. And as clinicians, as internists, we need to know how to manage our patients better. So we would like to thank the Information Management Service Network team of UP Manila and our sponsor, Viatris. Thank you all for joining us. We hope to see you all again in August for another informative and timely lecture. And I hope you have a great afternoon.
In this video, we will learn about the logical choice to maximize clinical benefit in osteoarthritis patients. Hip and knee osteoarthritis was ranked as the 11th highest contributor to global disability that often results in joint replacement surgery. The global prevalence of knee osteoarthritis was 4%, and the measures to stop the progression of the disease, reduce the impact on patients' quality of life, and restrict the burden on healthcare resources needs to be looked into. The European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis recommends that prescription crystalline glucosamine sulfate should be differentiated from other glucosamine formulations. Pooled results using the prescription crystalline glucosamine sulfate, a rotamycin preparation, was superior than placebo in the treatment of pain related to symptomatic osteoarthritis, whereas non-rotamycin preparation failed to show benefit for pain. Prescription crystalline glucosamine sulfate and paracetamol for rescue analgesia can only be used as background therapy for osteoarthritis, as recommended by the European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis. Viatril S, a prescription crystalline glucosamine sulfate, has showed superior outcome on pain with a small effect size of -0.27 compared to other glucosamine preparations. Different glucosamine preparations showed brand-specific heterogeneity in pain reduction. The effect size for Viatril S was moderate, and it achieved 48% reduction in the use of NSAIDs. The use of NSAIDs could be reduced by 36% and 48% by taking Viatril S for 2 months and greater than 4 months respectively. Viatril S is superior to other glucosamine preparations in the treatment of functional impairment resulting from symptomatic osteoarthritis. Glucosamine, administered orally as crystalline glucosamine sulfate, is bioavailable both systemically and at the site of action in osteoarthritis patients. Patients previously on prescription crystalline glucosamine sulfate experienced a 57% of reduction in the risk of undergoing total knee replacement. The cumulative incidence of total knee replacement was significantly decreased during a follow-up of 5 years in 275 patients with knee osteoarthritis, receiving oral prescription crystalline glucosamine sulfate 1500 milligrams once daily for at least previous 12 months. The European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis Task Force advocates the differentiation of prescription crystalline glucosamine sulfate compared to other glucosamine preparations. Prescription crystalline glucosamine sulfate is the logical choice to maximize clinical benefits in osteoarthritis patients.
O ano, magkuha na, picture. Picture na.
Hindi ako pwede. Naka-beach ako, beach.
Wow, si Sir Mike! Sir, nasan ka?
Ba't hindi mo kaya may sinama, Mike? Ikaw talaga.
Dito ako sa Anilaw.
I didn't get the paper.
Wow! Oh my gosh!
Chris na Webes, andyan.
Pero nakinig ako kay Lola Pen, ha?
Oh my God. Kali mo naman kami para may pag-asa yung buhay namin.
Nakinig ako kay Lola Pen. Kahit
Sama.
nakita ako sa beach.
Ayan, Mike.
Sarap na sarap.
Sir Mike.
Mike ha, bad yan.
Bigyan mo na yan, wala nang oras.
Oo nga, pagbigyan natin si Mike.
Congratulations, Lola Pen. Always.
Picture nung beach, kahit ikaw wala, yung dagat lang.
Oy, picture.
Dagat, nakakabit.
Wala ako. Oy, tingnan nyo, oh.
Wait, ang ganda ng blouse.
Ano, ma'am?
Ganda ng blouse.
Thank you, ma'am.
Mike, dagat.
Sarap, sir. Hanggang kailan ba, sir?
Pakita mo yung dagat, nakakaingit.
Hello po. Take some shots po for the photo op.
Kailan ko gusto
So,
i-vaccine na
give
wala
it
sa
your best
family?
smile po. Ready?
Kami, dito.
And 1, 2,
Wala akong video.
3.
Hindi ako video.
Kilig si Sir.
Start video.
Yung speaker. Hold on lang po.
Start your video because the host has stopped it. Host, you open my video.
Ayan po ma'am, kindly open it. Sorry. Ready po.
Okay, vitamin
Ready
D.
and 1, 2, 3. One more po.
Baby.
Laban sa
One
osteoporosis
more.
to.
1, 2, 3. Alright.
Thank you ha. I am tingnan niyo yung aking background ha. Sumusunod ako sa memo. Wala kang memo. Ganyan mo ka mo.
Hey, music, Maki!
Meron ng one reindeer.
It's okay po if we end the webinar. We have another schedule. Sorry.
Okay. Bye-bye po.
Bye.
Ingat po.